So I'll just introduce myself briefly. My name is Rob Cywes. I'm a surgeon, actually a pediatric surgeon, but I do some adult work. And for the last 20 years or so, my interest has primarily been in starting with sugar metabolism and then transitioning into obesity. And really, as my understanding of obesity has evolved, we realized that insulin and carbohydrates and diabetes are really the core aspects of understanding obesity, diabetes, and so many of the metabolic disorders. I'll try to link all of those together. And it's not that I'm looking for a ghost under behind every curtain. It's if you understand how insulin and how the liver works, you really get an idea of the majority of the diseases that we cause to ourselves, and the majority of diseases that we're going to die of as a species in the next 20 to 40 years, as smoking injuries decline, the effects of the carbohydrate insulin disease process will increase. So my approach is going to be very much a pathophysiologic story. Unfortunately, there's been so much bad science in this field, starting with me in Toronto, 1990. I did my PhD at the University of Toronto with David Jenkins, and he was on my committee. And a lot of the data that we provided just didn't fit our hypothesis. So what did we do? We did what all good scientists do. We massaged our data until it fit our hypothesis. And it took me another decade to realize that this wasn't correct. And as I started to deal more and more with obesity, I realized that the data actually fit better than our hypothesis, and we had to get rid of the hypothesis and really follow the data, and that's what I've done. So we started this process when we were pretty much a lone voice in left field. And I think there's now very rapidly a big crowd gathering, but we're still out in left field. So let's go ahead with this. As I go through this, please feel free to annotate questions and that kind of thing. And I'll focus on certain subjects, but there's so much to talk about. So I'm going to go ahead and get going. There we go. Okay, I've got my slides now. So what we'll do, we'll talk about a little bit about where we are today. I think everybody knows that. I'm going to give a brief history of how we got here, which is the history of lipophobia and carbophilia. And then I think the crucial part is to understand the pathophysiology and the mechanism of how diabetes and obesity evolve. And by the way, diabetes and obesity are the same disease. And that's a crucial understanding as we go through this. So we'll look at the cause, and then we'll look at some of the treatments for both diabetes and obesity, and what we can do then at a societal level to deal with the ramifications and the political and socioeconomic aspects of obesity. This really is, as it says over here, a new era in the management of obesity and diabetes, and I think all of you are on that team. So let's go ahead. I think this is a busy slide. It gives all the statistics and the data. I'm not going to be driven by statistics and data today, although everything could be supported by that. But the first place that we started was looking at obesity because obesity is so visible. And just for example, yesterday I had a patient in my office that was obese, and she's been obese for 20, 30 years, and her physician has never bothered to check her for diabetes. And her A1C, when we checked, it was 10.5. So the key thing about obesity, it's very visible, and we focused for a long time on that. Diabetes is not visible until something bad happens. So we have to think of it and test for it, because it's almost always going to be there. It's impossible to be fat and healthy, and that's one of the key things I tell my patients. Oh, no, I'm the lucky one. I haven't been diagnosed with a disease yet. Well, I'll explain why that's the case on this continent. But let's start the story. And I think the history of lipophobia and the history of carbophilia started in the 1950s. My favorite movie is a movie called Casablanca that was produced in 1943. And if you watch the movie Casablanca as many times as I have, there's only one fat person in the movie, and that's the owner of the opposing restaurant or the opposing bar. Everybody in the movie Casablanca looks like this. They're all skinny. Now, if you look at a normal person currently and you take them back into that time, they'd be considered to be overweight or obese. This is what normal looks like. But the interesting thing about this picture, in every frame of this movie, there's either a glass of wine or a cigarette or an ashtray, and you can see him smoking there. But in every scene, somebody's smoking and drinking or both. And what has changed? Well, in the 1950s, especially in this country, in the US, which is where I'm sitting right now, more and more people started dying of heart attacks and strokes. And we really were worried about this, but we had no clue about what the cause was. Clearly, it wasn't smoking because at that time in 1950s, smoking was perfectly healthy and there was really no harm from smoking. But Eisenhower had 5 heart attacks in the decade. He eventually died of a heart attack. So we as physicians started doing autopsies on people that were dying, and lo and behold, we found that the people that died of strokes and heart attacks had this type of injury in their blood vessels. They had these big lipid fat plaques that were blocking the blood vessels. And when you looked at lard, when you looked at bacon, it looked exactly the same as the fat we saw in our vessels. So we made the obvious connection. The fat that we're eating must be causing the fat buildup in our vessels, and that's what's giving us heart attacks and strokes. So we created the cholesterol lipid heart hypothesis. But remember, this is a hypothesis. It's a theory. It was untested. There was no evidence to support it. So what did people like Ansel Keys do in the day? They designed an experiment based on questionable data. They designed an experiment, and the experiment was a societal experiment to remove fat from the modern American diet. And as we removed fat and we conditioned people to be afraid of fat, we created this concept of lipophobia. All our food went low fat, no fat, and when you take the fat out of food, it tastes like that emoji right there. It tastes like crap. So what we did in order to add taste to the food and also reduce cost and beat hunger in countries that were facing starvation is we started adding fructose corn syrup, gluten fillers, carbohydrates into our food. But what we didn't realize is that no matter how much you dress up a turd is still a turd. But we removed fat from our diet, something we'd been eating as human beings for 200,000 years. And over the last 50 years, we've been very effective at removing fat and adding sugar, to the point that in 1977 in the U.S., we created the McGovern Commission created the food pyramid, which was 50 to 60% carbohydrates. The problem is, and still remains true to this day, is that carbohydrates are an incredibly powerful endorphin-releasing agent, to the extent that they compare with drugs like cocaine, morphine, even the heroines that we're on right now, the alcohols and the cigarettes. And that when we put these into our food, when we put carbohydrates into our food, we created a whole generation of carbophiliacs, of people that absolutely love the immediate high that you get from eating sugar. Can you imagine if I said to you, you know what, water is really bad for you. You have to drink whiskey with every meal. Most people couldn't avoid becoming alcoholics, and that's kind of what we did to our society. And over the last 50 years, that has built and built and built. So we're suffering from lipophobia and carbophilia. And what happened is, because of that kind of somewhat innocent or unsuspecting change, our population began to gain weight. We also became sick. And remember, in the 1970s, we realized that smoking was the cause of a lot of these strokes and heart attacks. But despite a rapid decrease in smoking, with the anti-smoking lobbies coming up, we still became fatter and sicker and more diabetic. So what did we say? Aha, okay, obesity is causing all of these illnesses we see on the right. And we created a hypothesis, well, if obesity causes all of these diseases, then weight loss must fix them. And we created this concept called calories in, calories out, CICO. It is absolutely true that the consumption of calories results in, the reduction in caloric consumption results directly in weight loss. There's no question about that. If you reduce your caloric consumption, you lose weight, and it doesn't matter what the formula is. And pretty much every diet process out there, whether it's Weight Watchers, Dr. Oz, Oprah, it doesn't matter who it is, Nutrisystem, they are all some pseudo-scientifically based formula for caloric reduction. And a lot of people add exercise in to burn off the calories. Well, that's the CICO hypothesis. The problem with this hypothesis, while it is true that reduction in calories intentionally does lose weight for a transient period of time, number one, the consumption of calories does not make people fat. Remember that. The consumption of calories does not make people fat. So reducing calories does get you to lose weight, but ultimately intentional caloric reduction is a form of starvation that is unsustainable in the long term. The human body cannot sustain long-term global caloric reduction. But CICO became the standard of care, and the ADA and the certified diabetic educators came, even in the management of diabetes, developed the CICO hypothesis for overweight diabetics. What happens? We get transient weight loss, we get transient improvement in comorbidities, but as I said, that's unsustainable. So what should this picture look like? Because if you look, obesity does not cause any of these diseases. There are only two things that obesity directly causes. Number one, obesity causes spine, hip, knee, ankle, weight-bearing joint disease purely because of the gravitational effect of the excess weight. And the other thing about obesity is most fat people don't look very good in a thong. Otherwise, all of these diseases are not caused by obesity. They are associated with diabetes. Exclusively chronic excessive carbohydrate consumption causes obesity and type 2 diabetes. And this is a crucial change in our way of thinking. If you lose weight, you may save your joints a little bit, and there may be a transient improvement in your comorbidities, but only getting rid of carbohydrates from your diet gets rid of the diseases that came originally from excessive carbohydrate consumption. So all of these diseases, every one of these, is directly or indirectly caused by chronic excessive carbohydrate consumption, even though it may be associated with with obesity. So we've got to change our perspective of what's associative and what's causal, and we'll come to that when we talk about LDL as well. So let's look at diabetes, because understanding obesity, we need to understand diabetes. Diabetes is basically a group of diseases that cause blood sugar to rise and not go down adequately. It could be insulin resistance, type 1, type 2, gestational, glucogonomas, a variety of different things. In order to understand diabetes, we need to understand what normal is. And normal is not the upper range of the tests that we do. Normal is an hemoglobin A1C, and I'm going to use US metrics here, but it's an A1C of 4.8 to 5%. If you start going significantly above 5%, even if you're below the standard 5.7%, you are already causing harm. And remember that hemoglobin A1C is the first measure of harm by sugar to the human body. It is damage to the hemoglobin in red blood cells by attaching glucose to those proteins. A normal blood sugar is between 70 and 85. It is not less than 100. So if your blood sugar is in the 90s or the low hundreds, that's not normal, even though the tests will call that normal. So we're looking at blood sugars of 70 to 85 and A1Cs of 4.8 to 5.0, where normal is not associated with disease. The next thing about diagnosis is very, very few people out there test insulin and C-peptide, and these are crucial in understanding both obesity and diabetes, and I'll get into those in a little bit. But the genetic capacity of any human being to produce insulin is at the cornerstone of this entire process, and it's critical that we measure that, probably more important than measuring all of these other criteria. The next thing to understand, there are two sources of blood sugar. The first and most prevalent one currently in our world is the mouth. And it doesn't matter how the sugar goes into your face. What matters is that it's glucose, fructose, or galactose that's entering your bloodstream. The second, and that is under the influence of insulin. The second place where we get sugar into our bloodstream is from gluconeogenesis, or the conversion of primarily protein to sugar, and that is under the influence of glucagon. The increase in blood glucose occurs by three separate pathways. In type 1 diabetics, there is a destruction of insulin production, so there's a reduction of insulin production in the pancreas. In type 2 and insulin-resistant people, the production of insulin is fine. It's the sensitivity to insulin that's the problem, so that the organs that should be taking the sugar up are not able to do their work effectively, particularly the liver and also the muscles, but primarily the liver. So while insulin is present, in fact, in supernormal amounts, there's an insulin resistance and the uptake of sugar is altered. And also, paradoxically, there may be an increase in glucagon production, which results in an outpouring of sugar that causes that increase. And that's an important aspect to understand. So when you understand that aspect, now I'm not going to delve into, I've talked quite a bit about type 1 previously in other talks I've given. For the sake of time, I'm going to skip over type 1 diabetes, but there are a couple of important points on the slide. A change in thinking. The primary role of insulin is not to remove sugar from the bloodstream. The primary role, the primary genetic and evolutionary role of insulin is actually to control fat metabolism. The very first thing that a rise in insulin does is it blocks lipoprotein lipase in the fat cells and prevents or reduces the release of fat in the form of ketone bodies or fatty acids from the fat cells. So when your insulin goes up, you're not able to utilize the primary fuel source that human beings are genetically designed to use, which is our stored fat. The secondary role of insulin is to remove glucose from the bloodstream. And when I say glucose, I'm using glucose, fructose, and galactose just for the sake of speaking. The secondary role of insulin is to remove glucose from the bloodstream. Another secondary function is to control glucagon release in the pancreas and also cortisol. So insulin suppresses glucagon and does help to remove sugar from the bloodstream. And the other point about type 1 diabetes, a carefully controlled type 1 diabetic, and not controlled by medication but controlled by diet, actually is healthier than the majority of Canadians and Americans that are out there on the street right now. Type 1 diabetes is only harmful if the blood glucose remains elevated or spikes. And the majority of type 1 diabetics treated by the glycemic index are also resistant to the very insulin they're giving themselves to control their blood sugar, which is kind of a bizarre thing, but we'll get into that in a few minutes. So over time, what has happened based on the glycemic index is the American Diabetes Association, the JDRF, those are our societies here in the US, have constructed a treatment paradigm that is both based on therapy rather than on understanding and dealing with the cause of diabetes. And one of the important reasons why it's critical that we understand what true normal numbers are, a blood sugar of 70 to 85 and A1C below 5, is because traditional healthcare only labels a disease when it reaches a treatment level, not a damage level. So you only become a type 2 diabetic at an A1C of 6.5. Well, what's happening inside your body between 5.0 and 6.5? What damage is happening? And that's what people don't understand. The majority of physicians do not call a disease until it reaches treatment level. They don't understand. We've lost touch with the pathophysiology of the disease process. And your body doesn't function based on numbers. It functions on process. So, in fact, the ADA specifically says, contrary to popular perception, there is no specific diabetes diet. And we all know that's absolute, well, the people in this forum know that's absolute garbage, but they will not alter from that advice. What they do focus on very heavily is this laundry list of medications that really don't, they reduce the rate of severity of the disease, but they do nothing to address comorbid disease and eventual death. So, if we continue this current diabetes management process, we ultimately are threatened with human extinction. There are plenty of things that have, but when humans do things to themselves, that is the most likely outcome, is human extinction. So let me take a minute over here and look at this evolutionary tree and what has happened with humans. And it doesn't show it that well over here, but the big change from this primate ancestor over here, which was typically a vegetarian ancestor that lived in the forests of Africa, to this person over here that roamed the savannas of the world and continuously expanded, the biggest change in these two animals, or in this evolutionary process, is this thing right here, the human brain. 65% of the human brain, at least, is made of fat, saturated fat, and about 25% of the human brain is made of cholesterol. The percentages are true, but the brain of these vegetarian primates is far, far, far smaller. And the big distinction between this person and this animal is that brain development. And one of the key things is that we cannot get the fat that we require to have a mature, effective human brain from vegetable material. So human beings did not evolve to eat fat. We evolved because we ate fat. And that is a critically important concept to understand. And the type of fat that we need to have the brain that we have to be able to become this person does not exist when you are a vegetarian. So we'll address that down the road, because we're dealing with two different things. We're dealing with what we should be eating and what we shouldn't be eating. But as far as humans go, fat is essential to our diet. Saturated fat is an essential component of our diet, without which we are unable to be effectively human. Let's talk about one other difference between our gorilla ancestors and our primate ancestors and us. Vegetarian animals and animals that live on cellulose as their primary source of calories have no mammal. First of all, no mammal can process cellulose. No mammal can process cellulose. So how do cows, how do gorillas live off vegetable material? They have a symbiotic relationship with bacteria in their intestine that breaks cellulose down. The cows and the ungulates and the antelope have very, very large stomach chambers with tons of bacteria in them, and the bacteria process the cellulose and break it down. Some of the primates, the gorillas, have very large colons that do the same function. And remember this, that all mammals, whether they're eating cellulose or they're carnivorous, do not absorb sugar. You can make a cow diabetic. In fact, we do that intentionally to geese in Quebec when we make foie gras. We intentionally feed them carbohydrates and they get a fatty liver. That's where a fatty liver comes from. So when vegetarian or herbivore animals eat cellulose and they live off cellulose, it's a very low yield. They're eating for 15, 16 hours a day, and the bacteria in their stomach are breaking the cellulose down, but they do not absorb sugar. Cellulose is a sugar. They do not absorb the sugar. The bacteria turn that sugar into fatty acids. So even your animals that are eating a very high cellulose diet, a very high sugar diet, the bacteria in their intestine are converting that to fat, to a fatty acid. And those fatty acids are what's being absorbed. If you feed a primate or if you feed a cow sugar, you can make them diabetic, and you certainly can make them fat. That's what we do in the prairies of both the US and Canada when we put our cows into feedlots. We don't feed them grass, we feed them corn, we feed them very high carbohydrate foods, and we fatten them up. Well, that's the same thing that we did to this guy. So all mammals can become fat, all mammals can become diabetic. And most people don't understand that. Now, when you look at the modern human, we do not have an intestine that can support the bacteria that breaks cellulose down. In fact, the only remnant of our cellulose breakdown is the appendix, which is a tiny little thing. I don't even have one in my body anymore. It was taken out 20 years ago. So we are incapable of processing plant material for energy to any significant amount. That's critically important. The plant material absolutely provides for the micronutrients, the minerals, the vitamins, the trace elements, and a fiber is an important part of the fiber, but it is not in human beings a plausible source of energy from cellulose. We have to add carbohydrates to our fiber to get energy from it. And that is why the plant-based diet, forget about the politics, forget about the emotion, forget about the religious side, forget about the ethics of animals. From a humanistic evolutionary perspective, a plant-based diet is not an effective diet either for our brain or for our absorption. And that is an important aspect for our patients to understand as well. So let's get back to the topic at hand. And I think what we've evolved from, certainly in what we're doing, is away from CICO, calories in, calories out, to what's called the CMOD, the carbohydrate insulin model of obesity and diabetes. And I'm going to go into this in a little bit greater detail, but the principles are to get our A1Cs below 5, or at or below 5, and get our blood sugar to actually 70 to 85, and our ketones below 5, keeping them somewhere between 3 and 5. Even for a type 1 diabetic, that is plausible, and if you do that, you have no comorbid disease. The rest I'm going to go into in a few minutes. So when we're talking about obesity and type 2 diabetes, let me ask you these questions. Type 1, I can discuss. If anybody has questions about that, I'd be happy to discuss that. But I've talked for a long time already, and I want to get through this. Ask yourself, what causes insulin resistance in type 2 diabetes? What is the cause of type 2 diabetes? The second question I want you to ask yourself is, which two human organs cause type 2 diabetes? What are the two organs responsible for diabetes? And who are vulnerable to diabetes? Which two groups of people have a vulnerability to becoming diabetic? And here are the answers. Exclusively, chronic excessive carbohydrate consumption causes insulin resistance in type 2 diabetes. There is no other cause of diabetes, period. It is not genetic. It is based on carbohydrate consumption, and anybody can become diabetic. Because the two organs that are responsible, not the liver, not the pancreas, not the kidneys, it is the mouth and the mind. It is putting carbohydrates into your face that over time results in either diabetes or obesity or both. And in fact, it does result in a degree of both. So who gets type 2 diabetes? There are two groups. The first one are endurance athletes who are carb loading. They are vulnerable to getting type 2 diabetes. And the second group of type 2 diabetics, I am calling drug addicts. Remember that, drug addicts. So let me explain these two. Here's what happens on what I call the standard American diet, or the food pyramid diet. If you look at the food pyramid diet, 50 to 60% of carbohydrates, what happens physiologically in our bodies? Well, the first point is this. It doesn't matter how the carbohydrates go into your mouth. It doesn't matter if they go in as an apple or as a bowl of ice cream. In fact, these two have a very similar sugar load. What matters is the sugar entering your bloodstream. It doesn't matter if you have a Marlboro unfiltered, a Camel Light, if you're vaping or if you're chewing tobacco, it's nicotine that enters your bloodstream. And in fact, we talked about Gary Fettke a little bit ago. I would urge everybody to go on YouTube at some stage and watch Gary's 20 minutes on fruit. Just download his YouTube video on fruit. He explains this so much better than I do about why fruit is not a good idea for most of us. But most of the people out there will say, oh, an apple's healthy, ice cream not so much. That's not true. If you look at the sugar load, they're identical. And let's see what happens when that sugar enters the bloodstream. When you eat a carbohydrate load per the food pyramid, your blood sugar spikes. And immediately, your insulin spikes as a result of that blood sugar, and it drives your blood sugar down. When your blood sugar goes down, you get hungry. And what do? You eat. So throughout the day, human beings on the food pyramid diet are having highs and lows in their blood sugar within relatively normal range, and they're getting spikes and lows in their insulin. And it's driving hunger. And every time they do that, if they are normal human beings, if they are either still insulin sensitive or in the early stages of stage 1 insulin resistance, that insulin causes the liver to suck all that sugar out of the bloodstream, and the liver is very effective at converting the sugar to fat, and then the fat gets shipped out to the fat cells. That is how obesity happens. This is the story of obesity. Exclusively carbohydrates cause this effect. A high protein or a high fat diet does not have this effect. And I'll come back to why it doesn't in a little bit. And remember that the consumption of sugar is a very powerful appetite stimulant. Because these people are in a state of glycosis and those insulin levels are pretty much always elevated, one of the very first things, remember I said that the primary role of insulin is not necessarily to get the sugar out of the bloodstream. The primary role of insulin when it goes up is to block the mobilization of fat. So when people are eating carbohydrates and they're snacking on a regular basis, and the advice by the food pyramid people is to have 6 or 8 small meals a day, or snack, intermittent eating is what that's called, they're continuously replenishing the glycogen in the liver, they're continuously producing fat, and because that's blocked, they're not able to burn up their fat. So when you've got an effective insulin production or insulin release mechanism by the pancreas, you can get really enormous. And the interesting thing is that the fattest people are often the healthiest. Yes, they got some joint disease, but generally they're healthy because as you produce more and more insulin, the liver starts saying, you know what, guys, I'm seeing insulin all the time. My insulin level is never, ever going down to a baseline, and I'm not going to react to low levels of insulin anymore. And that's the beginning of insulin resistance. So we see that when that's why it's so important to measure insulin. The insulin number starts creeping upward. And as that insulin level starts creeping upward, the liver is more tolerant to a small increase in blood sugar. So you get into the 90s, you get into the low hundreds. no doctor would bat an eyelid of a blood sugar of 95. They'd say, oh, that's normal. And an insulin level of, say, 10 or 15. Oh, no, that's fine. That's normal. It's not. It is not normal. It's the first stage of insulin resistance. And only testing your insulin levels is going to give that to you. As the liver becomes more and more insulin resistant, you now, every time you eat, you need to produce a higher amount of insulin. And the genetics of insulin production is crucial here because every human being genetically has a maximum amount of insulin that you can produce. And when you reach that peak, or as you get close to that peak, that insulin resistance is growing. That's the insulin resistance type 1 or stage 1. But in stage 2 and type 2 diabetes, you reach a cap of insulin production, as you can see in this bottom graphic, and the liver no longer responds to that. You can't produce more insulin. The liver can't remove that sugar from the bloodstream, and the sugar in your bloodstream starts to go higher and higher and higher. And over time, as your body becomes more and more tolerant to an increase in blood glucose, you cannot convert sugar to fat, so you don't really accumulate a huge amount of fat, but your blood sugar goes up, and over time, that glycosylates the hemoglobin, and your A1C goes up, and you call type 2 diabetic. But even if your A1C is a normal or a slightly elevated level, let's say 5.7, 5.8, you are still in severe insulin resistance, and your blood sugar may be 110, 120. Your body is suffering the consequences of that damage. And I'm going to show you what the damage looks like in a second. So don't be fooled that insulin resistance is safe and only diabetes is bad. That process is bad no matter where you are. So let's look at a normal human diet. Well, the normal human diet, the way our ancestors ate and the way the LCHF movement works, when you're eating a low carbohydrate, high fat diet, which we've been consuming for 200,000+ years as human beings, the first thing to understand is that when you're in ketosis, when you are burning fat as a fuel source, it is a very powerful appetite suppressant. So because of that leptin response, and leptin responds to fat, which is a hormone that suppresses hunger, we don't need to eat, and therefore we're not very hungry. And if we get to a point where we're eating once, maybe twice a day. Now, what's become very sexy over the last couple of years is this whole concept of intermittent fasting. Well, that's not something that should be intentional. It's something that happens vicariously as you start to live off fat rather than sugar. You're eating once or twice a day, which means for a long period of time, you have a basal level of blood sugar and your insulin level is basal. When your insulin level is basal, your insulin sensitivity returns slowly over time. Typically, that return of insulin sensitivity takes about 8 to 12 weeks when you begin an LCHF diet. And that's why there's always a lag phase, where the weight loss and the return of and the improvement of the diabetes is not necessarily directly measurable like it would on a low-calorie diet. But what we want to promote with our patients is don't eat if you're not hungry, because leptin's working. And slowly over time, if you can reduce your meals from 6 to 8 times a day to maybe 1 or 2 meals a day, which is the intermittent fasting, where you're doing a 16-8 or a 22-2, over time, your insulin sensitivity returns, you start using your own fat, and the best place for a fat person to get their fat from is their own fat cells. To artificially supply ketones is only effective for a skinny person. It is not a good idea to provide ketones to get someone to ketosis. You want them to eat intermittently, to have that intermittent fasting, and to use their own fat to get themselves into ketosis. And that's the way you restore insulin sensitivity. You suppress appetite with leptin, and you get rid of your diabetes and your obesity, and this then becomes a permanent solution as long as you can stay in ketosis. Okay, so let's look at what diabetes actually is. Let's look at the damage that diabetes causes. And diabetes is a blood vascular problem. It's a disease that affects every organ that is supplied by blood because of the following graphics. And this is what I did my PhD on in Toronto. So when you look at a normal blood vessel, the endothelial cells, the cells that line the blood vessel, should be like fried eggs. They should be flat. They should be touching each other's arms on the sides, but they should be very flat. Well, a flat thing doesn't hold a lot of fluid. And under these conditions, there's laminar flow, you've got a very wide lumen, your blood pressure is low, and a normal blood pressure should be around 110/60, by the way, not 120/70. And under these conditions, blood flow is good, the surface is nice and fluid, there's no stickiness on the surface. That is healthy. When your blood sugar is 70 to 80, these cells are in that shape. When you have a carbohydrate load, or as your blood sugar starts to rise, sugar, every molecule of sugar is attached to a molecule of water. And glucose very rapidly enters these endothelial cells without insulin. It's an insulin insensitive or an insulin independent action. And the sugar enters these endothelial cells. Well, they drag water with it. So an endothelial cell, a flat endothelial cell cannot hold a lot of sugar or a lot of water. And what happens is these endothelial cells round up. And as they round up, two things happen. Number one, they reduce the width of the lumen. And that width causes back pressure, causing hypertension. So your blood pressure starts to go up. And when you look at most people that have, oh, they've got essential hypertension, we don't know what causes it, that's absolutely not true. The majority of hypertension is actually carbophiliac hypertension. It's carbohydrate-induced hypertension because it goes away very, very quickly when you get rid of the sugar. In fact, one of the problems is getting people off their blood pressure medication quick enough as they come off the carbohydrates. But nevertheless, what the sugar does is it rounds up these endothelial cells. And the other problem is that the endothelial cells now separate and they leave little gaps. And this gap, instead of being anticoagulant like the surface over here, it becomes procoagulant. And what happens is little clots form, fibrin clots form, and platelets plug into those clots. And my PhD was looking at these platelets. Platelets becoming activated, they become inflamed, and as these clots grow in the small little vessels in the end organs, the little capillaries that are right at the end of the organs, those little clots block the lumen. Now you're not getting oxygen, you're not getting blood going down, there's an inflammatory response here, and the organs, the little end organs or the little bits of the end organs that should be supplied by these capillaries don't get food, they don't get oxygen, and they die. And that disease, that process I've just described, is diabetes. That is diabetes. And it happens not when your A1C reaches a certain number. It happens as soon as your or it begins to happen as soon as your resting blood sugar is above about 75 to 80, 80 to 85. Certainly in the 90s and the 100s and the 110s, we start seeing this effect pretty dramatically. Now your body's resilient, it can break these clots down fairly easily, so there's an ebb and flow of these clots, but as long as you've got the sustained blood sugar effect, this is the effect that happens. And every organ from the brain to the toes gets affected by this, and this is the disease called diabetes. Now, let's look at the bigger blood vessels. Let's look at the big arteries that go to the heart, that go to the brain. Well, exactly the same process is happening. The endothelial cells are swelling up, but the other interesting thing is not only are these endothelial cells closing up, but remember that the big blood vessels, the arteries, have their own blood vascular system, which is called the vasa vasorum. The vasa vasorum are the blood vessels that live in the wall of the blood vessels, giving the blood vessels nutrients and oxygen. And this process is happening in the vasa vasorum, and this process is happening in the big blood vessels. But here's what happens. The same process happens, the clot forms, but that injury these clots don't coalesce. That injury doesn't block the vessel. It certainly narrows the vessel. But what happens over time, if these clots are not dissolved because you've got repetitive injury, the clot stabilizes. What stabilizes the clot? If you think about me punching a hole in the wall, if I punch a hole in the wall, you come along with some plaster and you plaster over the hole. That's what the body is doing continuously. Well, what's the plaster of the body? Cholesterol and apoprotein B. So the cholesterol infiltrates this plaque to stabilize the plaque. That is where this heart hypothesis, the lipid heart hypothesis, came from. And that comes from a sugar response, not a fat consumption response. If you don't have this, the fat's not going to stick here. And then because of the inflammation that occurs in the vasa vasorum, these clots become inflamed, the platelets become activated, that clot ruptures, and the clot travels downstream, called an embolus. When a clot ruptures and it goes downstream, and in the little parts of the blood vessels, that clot blocks the blood vessel. Guess what that's called? That is a stroke, that is a TIA, that is a heart attack. That is the mechanism by which sugar kills people. Now, interestingly enough, what other toxin, apart from sugar, what other toxin causes exactly the same injury? Nicotine. Nicotine does exactly the same thing. It damages the endothelial cells. You get the same clot forming, and that's why we see this injury in smokers as well as carbophiliacs or fat or diabetic patients. So this is from my PhD. Dr. Holloway and myself created these images. This is an electron micrograph of a normal blood vessel. Now it's in the liver, which is where I did my work. So the blood vessel should look like fried eggs. Here you see a beautiful picture of a healthy endothelial cell. Looks like a fried egg, and this is what it looks like in the lumen. So a nice open lumen. When I experimentally added sugar to those livers, here's what happens. Under glucose or fructose, those endothelial cells they shrink down and they swell up. Here you can see them swelling up, and they expose the underlying basement membrane. And along come the platelets, and they start to stick to that. Here you can see some of these platelets sticking, and you can see that lumen narrowing down. Here you see the same effect. And what happens over time, these platelets get activated. Those are normal platelets. These are activated platelets. Those platelets form the clump, and the clump blocks the blood vessel. There's inside of this, there's a blood vessel. Here you see it a little bit better. There's a blood vessel inside of that, but the entire blood vessel has been blocked with a blood clot. That is, you are currently looking at diabetes. That is what diabetes looks like in your blood vessels. And you can tell there's not a lot of blood or food going through that. Here you see the same effect. That is the disease we're treating. We're not treating a number. We're not treating blood sugar. We're not treating an A1C. We are treating blood clots. And I'll come back to the effective treatment of blood clots in a second. So to understand our change in perspective away from CICO towards CMOD, the carbohydrate insulin model of obesity and diabetes, we've got to remember that our fat cells are our genetically developed energy reserves. What human beings were designed to do is consume a meal. And remember, when humans and we're eating an animal, we're more carnivorous. We eat that animal over 1 or 2 hours. We eat that food. Our liver very rapidly stores that food in the fat cells, and in between meals, we use that stored fat for a long period of time. If you're eating once or twice a day or once every other day, you use that fat that you've stored. So our fat cells are our genetically developed energy reserves, and here's the key thing. From birth to death, humans are designed to be in ketosis. In fact, newborn babies are born in ketosis. That's what brown fat is. Fat cells are not the recipients, but are the recipients, not the drivers of obesity. So they're somewhat innocent in that effect. And a lot of studies are being done on the inflammatory effects of fat cells, but that's a consequence, not a cause. Human energy balance is, as I said, dependent on the ebb and flow from the fat cells, and that requires intermittent fasting and a certain amount of aerobic activity to drive that physiologic hunger. The next critical point. Everybody out there tell you, okay, well, if you're not eating carbohydrates, you must eat protein, lean protein. That's what human beings were designed to eat because we're still suffering from lipophobia. That is false. Fat is our primary macronutrient. It's our primary energy source. Protein is only a backup energy source. Protein is only there when we don't have fat available. It is counterintuitive to think that my muscles are my primary source of energy. That's where we store protein. No. Protein is only used as a fuel in terms of gluconeogenesis. Protein is not a primary fuel. It is the backup in states of starvation, but fat is our primary fuel. Protein is primarily a nutrient that should be used for tissue repair, tissue building, and as a hormone. A little bit of protein does go toward blood sugar because human beings are genetically designed to be in ketosis, and we are supposed to get our blood sugar not from our mouths, but from our liver. And we always retain a little bit of that sugar in the liver because that is our first responder. When we come around a corner and we face a saber-toothed tiger, we have to be able to run away very quickly, and that is the little bit of glycogen that we store in our liver, which is the first responder. It's the nitrous, for example, in a racing car that gets it to overtake another car. But insulin primarily regulates fat metabolism. Then along those same lines, insulin also regulates cholesterol metabolism. So for those of you that are worried about diseases like polycystic ovarian syndrome and the ubiquitously low vitamin D and low testosterone, how does that work? And I don't have a graphic, so I'm going to talk about this. Where estrogen, testosterone, and cholecalciferol, which combines with vitamin D, come from, they originate as cholesterol. And through a series of enzymatic pathways, cholesterol becomes estrogen, the sex hormones, it becomes testosterone, and it becomes cholecalciferol that combines with vitamin D. Insulin. Elevated insulin blocks the first enzymatic step in the process of cholesterol metabolism. So when people have polycystic ovarian syndrome, when they have low testosterone, when they have low vitamin D, in large part, that comes from an elevated insulin level. And PCOS is a direct consequence of chronic excessive carbohydrate consumption. In fact, in my practice, the greatest comorbidity that I have is pregnancy, because 12% of my patients, when they go on a ketogenic diet, get pregnant because their fertility returns very quickly when their PCOS goes away. We treat PCOS with metformin. So remember that insulin is primarily designed to regulate fat metabolism and cholesterol metabolism. It's a key component there. And excessive carbohydrates get converted by the liver to triglyceride, to LDL, VLDL, by the liver. That is also an insulin effect. So harm does not come from dyslipidemia. It's not the cholesterol that causes the harm. It's the vascular injury. And the cholesterol is there when you have a higher rate of injury. The cholesterol is there in excess to try to heal an injury. It doesn't create the injury. That's a critically important concept that is against the lipid heart hypothesis and pro the CMOD hypothesis. So how does LDL work? I said we were going to talk a little about the LDL paradox. LDL is basically a transport molecule. Think of an LDL like a barge between the liver and the fat cells, back and forth, transporting fat molecules. The three molecules that LDL primarily transports is fat, triglycerides, it transports cholesterol, and it transports lipoproteins, apoprotein A and apoprotein B, primarily B. So when you are in a ketogenic state, the LDL is primarily transporting fat to and from the liver and the fat cells, and it's a fat transporter. And even though when you go on a ketogenic diet, your LDL may rise, that's because you've got more fat to transport. Some of the triglycerides are in the bloodstream, but if you notice when you go on a ketogenic diet, your blood triglycerides rapidly drop. In fact, one of the associations with the greatest harm is an elevated triglyceride level when you're eating a lot of carbohydrates. Those triglycerides come from the conversion of sugar to fat that spills over into the bloodstream that can't even be transported by LDL. But your LDL level stays the same or rises paradoxically when you're on a ketogenic diet because it is a fat transport molecule. At the same time, your triglycerides drop precipitously. And most of my patients have triglyceride levels under 75 off any medication when they're on a ketogenic diet. But when it comes to obesity and when it comes to heart attacks and strokes, it is the cholesterol and the ApoB transport that people measure. So LDL doesn't cause that injury. LDL is just taking cholesterol and ApoB from the liver to the injury sites. And that's why LDL has been blamed. But LDL is not causal. It is associated with it. And if your LDL levels are elevated on a carbohydrate-rich diet, the LDL should not be reduced artificially with statins because it's actually fixing a problem. The LDL should be recognition that you've got a problem and you should reduce your carbohydrate consumption. HDL is so-called good cholesterol because it's actually the molecule that helps to remove lipoproteins from these injury sites. But LDL is the fireman. It didn't start the fire. It's not the arsonist. So that also completely debunks the LDL hypothesis of causing heart attacks, but it also explains why on a ketogenic diet, LDL levels remain fairly high. And in fact, the paradox is they go up. The more important numbers to look at on a ketogenic diet is that your HDL goes up dramatically and your triglycerides fall dramatically. And those three components are critical. The rise in HDL, the drop in triglycerides, and the stabilization or the remaining stable of the LDL or slight increase in LDL. The total cholesterol is completely irrelevant because it's a summation of the HDL and the LDL. The most effective drug to treat people with dyslipidemias is not statins, it's aspirin. Because aspirin is a thromboxane A2 inhibitor, and aspirin blocks the inflammation of the platelets. So aspirin, more than any other drug, helps to reduce that tremendous blood clot that I showed you in those schematics. And in fact, in my work in the lab, aspirin was the single thing that reduced or prevented the type of injury we were seeing when we artificially increased the sugar content of those livers. Why do we not talk a lot about aspirin? The most important reason is I've never, ever met an aspirin rep. But every day in my office, the statin reps are breaking down my door. People are making a ton of money off statins. Statins have zero value. They may lower your cholesterol numbers, but they do not. There's no evidence to support the fact that statins reduce the risk of heart attacks or strokes. And that's very important. So when doctors put you on a statin, they don't say, oh, take the statin, it's going to reduce your risk of a heart attack or a stroke. They cannot say that. What they tell you is the statins will lower your cholesterol. Sure, they will. But they will not reduce your risk of a heart attack or a stroke. So we're conning our patients. Everyone thinks, oh, my cholesterols are low. Well, yeah, you've artificially reduced the number, but you haven't changed the injury. The better thing to put your patients on is a low-dose aspirin. And that is where the CMOD science clashes with the cholesterol beliefs. And sadly, the beliefs are still overwhelming the science. Let's move on. Just briefly about endurance athletes. And this is Tim Noakes' work, who wrote The Law of Running. And Tim was my professor of physiology when I was in medical school. So I've known him since 1980, 81. These athletes are primed to eat carbohydrates. So they have exactly the same injury we're talking about. And that's what I call the Dead Runner Society. These are these marathon runners, these ultra-marathon runners that drop dead in their 50s of a heart attack or a stroke. How can a distance athlete be sick? Well, it's because of that carbohydrate effect. These guys, the runners, are skinny. They're lean. But remember, they're eating the carbohydrates and they're burning the calories off. They're focused on the CECO part. But carbohydrates are toxic at ingestion. You cannot burn them off. You cannot outrun a bad diet. And if you have to exercise to keep your weight stable, you're on the wrong diet. So one of the key things about athletes is the best energy source to run on is actually ketones once you're fat adapted, not carbohydrates, because you've got an endless supply and you don't have to consume these carbohydrates. And that's the endurance athlete side. So when we call people with type 2 diabetes endurance athletes, a large percentage of endurance athletes who carb load are type 2 diabetics when they get into their 40s and late 50s. And certainly the majority of endurance athletes have insulin resistance, most likely type 2 insulin resistance, stage 2 insulin resistance. And that's where they're getting the heart disease from. Nobody smokes 3 cigarettes and goes for a run to blow off the nicotine, because you can't. It is ridiculous to expect someone to be able to eat a tub of ice cream and then go for a run to burn off the damaging calories. It doesn't work that way. Okay. What does the ADA recommend and the certified diabetic educators? A balanced diet, the glycemic index. My friend in Toronto. And then they put you on a bunch of medication to control your blood sugar. And then they talk about lifestyle modification, exercise. Well, in my practice, here's what happens when those patients come in. All the people that come into my practice have been on some regimen like this. And here's what happens. Less than 10% of my type 2s are able to follow a glycemic index for greater than 6 months. Less than 50% of my type 2 diabetes actually even take their medications as prescribed, and less than 20% ever check their blood sugar, let alone checking it regularly. Less than 15% of them have sustained blood glucose less than 100 or an A1C less than 6.8. Remember, we diagnose diabetes at 6.5, but the ADA will tell us the treatment goal is less than 7. That's ludicrous. Look at the damage between 5 and 7. And 75% of my type 2 diabetics are on at least one other medication for hypertension, reflux, statins or aspirin or CPAP. Why? Well, here's an interesting study that was published by Dansinger in 2005, and it looked at all the diets, including the Atkins diet. And the ketogenic way of life should not be sold as a diet, and I'm going to clarify that in a couple of slides' time. But whether you look at Atkins, Ornish, Weight Watchers, the Zone diet, if you look at the total weight loss at 1 year, 4.8, 7.3, 4.9, 6 pounds. These aren't even kilos, these are pounds. For most fat people, that's a large bowel movement. That's not weight loss. And look at the number that were able to complete 8 weeks. About 50 to 60%. So that means a 40 to 50% dropout rate at 8 weeks. This is supposed to be a lifelong therapy. And these people can't sustain it for 2 months. You don't get into fat adaptation before about 8 to 12 weeks. So all of these diets, and when you think about putting your patients on a diet, I believe that that is the wrong thing to do. And certainly an intentional diet, which is basically a form of caloric reduction, intentional caloric reduction, is ultimately a form of starvation that defies satiety. And adherence is impossible, as you've seen from these studies. You cannot break habits if you are still doing them. You can only sustain a change if you remove the old and replace it with a new habit. So the low-carb, high-fat way of life, it should not be seen as a diet. It should be seen as the single best treatment for obesity and all of the metabolic diseases. And if you approach it from a therapeutic perspective, like the majority of doctors put their patients on metformin or on insulin for life, that's the way you want to approach it for your patients. Now, let's go on. I've babbled a lot, so please forgive me if I'm going on very long. But the next part is the crucial change in terms of this being a diet versus the understanding the psychobiology of diabetes and of carbohydrate excess. As I've tried to explain, carbohydrates have no place in our nutrition. Nobody would die if they never ate a carbohydrate again. Carbohydrates have a far greater drug than a food property. When you eat food, the reward is satiety. When you eat carbohydrates, you get high, like you do from nicotine, alcohol, crystal meth, crack cocaine. And sustainable treatment doesn't require a nutritional approach, a dietary approach. It requires a cognitive behavioral substance abuse approach. Why are my patients using carbohydrates in excess to the point of harm to get high? We should not be using a nutritional or a balanced approach, because you cannot treat an addiction with a balance. You cannot balance a relationship you've lost control of. So let's look at food versus drug. And I put carbohydrates not in the nutrition or the food category, I put it in the drug category. So let's look at the genetics of homeostasis. When I said before, it is impossible to get fat from eating protein or fat. It is biologically impossible for this reason. As I said before, our primary source of energy is fat, with protein as a backup and primarily therefore blood glucose from our livers in the form of gluconeogenesis. Both protein and fat also have a nutritional role, but nutrients come from fiber, minerals, vitamins, micronutrients, and electrolytes. Both of these, the consumption of nutrients and the consumption of energy, are under very tight control. They're under very tight control by the hunger center. Both the quantity and the frequency are regulated by the body's needs. And the hunger center regulates the consumption of vital nutrients and vital energy with satiety, the reward center of the brain. And so when you sit down to eat, let's say you're eating a salad and a steak, and you start to eat that salad and the steak, and let's say on the salad you've got some olive oil and some cheese, and on the steak it's a nice big ribeye steak with a big chunk of fat. You start to eat that food, and your brain might say you need a certain amount, and you start eating that certain amount. But within 5 to 10 minutes of beginning to eat, especially that olive oil or that fat from the steak, fat is a very powerful activator of a hormone called leptin. And leptin goes through the bloodstream to the brain and starts to make you feel full. And as soon as that leptin is powerfully activated in a normal person, you feel full and you stop eating. That is a leptin response, and it is very, very tightly controlled in a feedback pathway by the hunger center. Could you eat more? Hell, sure you can eat more. But there is zero incentive to eat more because you feel full, and the food that you're eating here and here does not get you high, so there's no added incentive to eat. Exactly the same with water. The thirst center is very, very tightly controlled, or controls our hydration in a feedback pathway. So if you're thirsty, you start drinking, you have no idea how much you're going to drink, you start drinking 1, 2, 3 bottles of water, it doesn't matter how much. At some stage, your stomach sends a message to your brain that says, hey, my thirst is quenched, and you stop. You don't have to predetermine how much you're going to drink, and although you could drink more water, there is no incentive to drink water, and both the hunger and the thirst center very tightly control your energy and your hydration balance. Let's now look at drugs. Let's look at alcohol. Alcohol and water are both things that human beings drink, but nobody would think of alcohol as something we drink for hydration. The primary reason we drink alcohol is for pleasure, for endorphin activation. And the key thing, so alcohol is really a drug, even though it's a liquid that we can drink. The key aspects that differentiate a drug like alcohol from something we drink for hydration are these. Number one, alcohol is not necessary for human survival. Obviously, water and water-like substances are necessary because without hydration, we die. Secondly, there is no feedback loop. There's no negative feedback loop when it comes to drinking alcohol as there is for food and hydration. Remember, carbohydrates are not a food, they're a drug. The quantity and frequency is primarily regulated by emotional need and by the activation of the endorphin center. And the more you eat, the higher you get, the greater the sense of gratification, the more buzzed you get, and the incentive is continuously positive. There's no negative incentive. So there's a powerful incentive to consume carbohydrates and alcohol to excess. So carbohydrates are really a drug similar to alcohol, not something that we need for hydration or for food. And that's a crucial change in thinking, particularly when you're talking to our patients, because this makes our patients more like drug addicts rather than just like fat people. So the other key thing is carbohydrates don't cause harm. We have a system in place that can handle small amounts of carbohydrates. However, it is a diabetic or an obese person's relationship with carbohydrates that causes harm. Alcohol doesn't cause harm. I drink alcohol, and in fact, I use alcohol from time to time as a very beneficial way to make me feel good. It's a great endorphin releaser, and it's a very powerful positive force. And if I drink a glass of red wine, particularly from South Africa, best red wine apart from that from the Niagara Peninsula, you get antioxidants with it, healthy. But no matter how healthy that red wine is, if I'm an alcoholic, it is not a good idea. So it's not about the alcohol specifically, it's about a person's relationship with it. And carbohydrates are exactly the same. A skinny person can eat carbohydrates, a skinny non-diabetic person can eat carbohydrates from time to time and be absolutely fine because they can control that relationship. A diabetic or a fat person, by definition, has suffered harm as a consequence of their chronic excessive consumption of those carbohydrates, and therefore, by definition, they have a substance abuse problem. They've lost control of the relationship. Not only do they have a substance abuse problem, but in addition, those carbohydrates are so effective, like the alcohol, at numbing, soothing, and obliterating their emotions. It just makes us feel good. It settles us down. It helps us to deal with emotional distress, but it disconnects us from the issues that are driving that emotional distress. So in addition to having an out-of-control relationship from a harm perspective, a substance abuse perspective, all fat and diabetic people, by definition, also have a dysfunctional emotional management system where they are doing immediate gratification and they're numbing, soothing, and obliterating their emotions. They're not dissipating their emotions and connecting with the underlying issues. They're, in fact, repressing the issues with the drug. Exactly the same way that alcoholics repress issues with a buzz from alcohol. Smokers do the same thing. Crystal meth addicts and heroin addicts do exactly the same thing. So addiction happens when the harm is ignored and the behavior is continued, and by definition, that's a loss of control over the relationships. And if you talk to any fat or diabetic person for the first time and you explain this to them, and it's important to understand this, that you want to introduce this topic slowly to them, because we have an incredibly sophisticated mechanism of minimization and justification and trivialization, rationalization, to the point that we don't even acknowledge that it's toxic. If you ever tell a smoker, man, that's disgusting, why do you smoke? You get this vomit of rhetoric from them. They're not talking to you, they're validating and justifying that to themselves. And it's exactly the same that obese and diabetic people do to you when you bring up the concept of carbohydrates. And that's the battleground. We're not the enemy. We're not calling them out. We're helping them to call themselves out. So let's look at the psychophysiology of obesity. And the same is true for any drug. Healthy people have a variety of emotional needs: anxiety, stress, boredom, sadness, pleasure, depression, fear, and most normal human beings, or all normal human beings from this perspective, have a diversity of what I call action-oriented internally generated endorphin releasing things. You can go for a walk. You can go to church or have a connection with a higher power. You can listen to music. You can go out in the yard and weed. You can have an effective, empathetic, vulnerability sharing relationship with another human being. There's a variety of endorphin releasing things. You can drink a glass of wine. Healthy people have controlled snacking and controlled carbohydrate consumption that they use from time to time. This is what an addict looks like. An addict, a fat person or a diabetic, uses carbohydrates and the act of snacking as a way to numb, soothe, and obliterate these emotional needs. Now, we haven't talked about snacking yet. Remember that in the 1970s, we started getting away from 1 or 2 or maybe 3 meals a day that we used to eat prior to that, certainly prior to 1950, and we started, because of the food pyramid and because of that spike and drop in blood sugar, we started advocating for 6 to 8 small meals a day. And in fact, because carbohydrates are a drug, we start eating more and more like smokers smoke. Nobody smokes 1 pack of cigarettes immediately in one go. We don't just sit down and smoke a pack of cigarettes. We have a cigarette here, a cigarette there, a puff here, a puff there, and throughout the day we're accessing those cigarettes, and by the end of the day we smoke 20. Why is that important? Because in the carbohydrate era, when we're eating meals, normal people in ketosis should be eating once or twice a day for the nutritional value. When you're eating carbohydrates for the emotional value, the endorphin system is something that controls brain function. The human brain can only function at peak optimum function for around 20 to 30 minutes, and then it needs a break. The endorphin system is the system that activates that break. And every human being can be defined by the dominant thing that they do to activate the endorphin system to give them that break. The smoker's always outside looking for a cigarette, and the fat person is always out there looking for a snack. And what we do is we surround ourselves with easy access to our drug of choice. We have our cigarettes in our pocket, we have our little snacks and our little eats and our little drinks close to us, and we're popping a little bit here and a little bit there, and we're not even aware of how often we're doing that. But if you add that up and you add it up, by the end of the day, it's a massive amount of carbohydrates. And the carbohydrates are so darn effective. There's easy access. They're a powerful drug. They're so effective that we lose all the other tougher, more effort-requiring alternatives to managing our emotional needs. And when this happens, and the same is true for all these other addictive behaviors, when that happens and we develop comorbidities, we become fat, we become diabetic, and we ignore the harm to continue the relationship, and we justify and validate that relationship is out of control, we have an addiction. So by definition, all type 2 diabetics who are not athletes, who did this vicariously rather than intentionally, are actually drug addicts, as is true for obese people. And we've got to understand that this is a substance abuse problem. Okay, so how do we deal with that? How do we effectively treat our patients? If you put them on a diet, you're reducing the amount of carbohydrate they're eating. Well, that's like telling a smoker to cut down from 20 cigarettes a day to 2 cigarettes a day, or telling an alcoholic, you know what, this whiskey makes you drunk very, very quickly, so don't drink whiskey. Drink a light beer, it makes you drunk more slowly. That's exactly what the glycemic index is. The glycemic index is, hey, don't eat these things, they raise your blood sugar very quickly. Eat these things, they raise it more slowly. Think about how, if you treated an alcoholic according to the glycemic index, they're still drinking. The glycemic index, the glycemic load, is garbage, and it's a terrible way to treat a diabetic or a fat person. The appropriate way is to help them progressively to remove the carbohydrates from their diet and base their macronutrient consumption on what human beings are designed to use for our energy, which is fat. And that's where the no carbohydrate LCHF movement comes from. And in addition, when you're eating carbohydrates and you return away from the endorphin way of eating to the nutritional way of eating, you also want them eating once or twice a day. And remember, a snack is always an emotional event. A snack is always an emotional event. It is never a nutritional event. Now, the truth is that that smokers and obese or diabetic people, we still love to put things in our mouth. But instead of smoking the cigarette, use the gum. Instead of eating that carbohydrate-laden or calorie-laden little snack, find something you can eat and drink throughout the day, or preferably just drink throughout the day, that gives you that endorphin release without causing harm. Now, I haven't said this about myself. I used to weigh 300 pounds. I used to be a fat guy, and I've lost about 90 pounds. When I was fat, it was Coke and M&Ms that I would have around me all the time, and I'd be snacking on them through the day. Now it's a cup of coffee. The coffee has exactly the same endorphin-releasing effect, but there is no caloric load, so I'm not contributing to my obesity and certainly not to my diabetes. When you do this, now you're leaving the patient with a complete deficit of emotion management systems. So it's critically important you help them to develop at the same time, or make them aware of developing what I call endorphin alternatives. And the endorphin alternatives can come from 4 categories: the creative arts, spirituality, which is really a meditative event. It doesn't have to be religious. Physical activity is a powerful, powerful genetically based endorphin releasing mechanism, and human connection through empathy and vulnerability, which Canadians are so much better at in general than Americans. So one of the key concepts in our change when we're dealing with LCHF is not to try to get patients to control their diet, but to really work toward abstinence of carbohydrate consumption. And that's the difference between a diet and an LCH way of life. Even if the diet is a low carbohydrate diet, it is still control. You're asking someone to control something they've lost control of. So asking an obese or diabetic person to control their carbohydrate consumption is like asking an alcoholic to control their drinking. It takes one emotional event and they're back doing it. What has to govern our treatment is the word permission. And permission is very binary. Nobody gets drunk from one sip of beer. But the reason an alcoholic shouldn't have that first sip is because once they grant themselves permission, that together with an emotional event, they can't stop. And exactly the same is true for sustainability with our obese patients or our diabetic patients. Once they grant themselves permission, or you give them permission within a controlled diet of having a little bit, they can't stop. I've never met a fat person who can eat one chip out of a bag or eat one block of chocolate out of the slab. Once that slab is there, it's gone. Just like alcohol, just like smoking. However, where carbohydrate addiction is different to all other addictions is from a sustainability perspective, you're now removing the carbohydrates, you're leaving two instead of one deficit. You're not only leaving an emotion management deficit, you're also leaving a food deficit. And the goal is to be able to help those patients to replace both. The food deficit is what's called real food. If you can, for the most part, look at a piece of food and tell which animal or plant it came from, it's going to be very healthy for you. If you look at a piece of food and you have no idea where it came from, if it's been the more processed it has been by human beings, the more we've taken the fat out and the more we've added sugar. So we try to get our patients to primarily eat real food minus fruit, rice, and potatoes. Now, here's something that's critically important. I'm going to clash very heavily with the diet-based, the macro-based ketogenic people and the LCHF people. Apart from rice and potatoes, vegetables are free, irrespective of how much carbohydrate they contain. In the substance abuse plan, in the carbohydrate addiction way of life, I've never ever met a fat person or a diabetic or any other human being that after a rough day rushed to the fridge for carrots or rushed to the fridge for broccoli. So therefore, we do not need to count the carbohydrates in vegetables. And this has been our approach for a long time with a great degree of success. We use 30 grams of total, not net because the human body cannot do mathematics, total carbohydrates, what goes in my face. But vegetables are free. And I'll argue that point over and over with anybody. But you can get into ketosis very readily. The only time we look for a degree of moderation is with vegetables, and because they're not endorphin stimulating, people don't overeat vegetables. If they do, then we've got to back off. But absolutely rice and potatoes we do, that's why they're on the low list. So we have to remove the carbohydrates and add soluble fat to our diet. What's soluble fat? I call them my 5 fat friends. Butter, olive oil, whole mayo, cheese, heavy cream, sometimes whole milk. Those are my fat soluble or my soluble fat friends that I often add to my food because of the deficit of fat, even in American real food. And that addition of that soluble fat activates leptin and gives us a sense of satiety very early on. So not only are you eating less often, you're eating far less without intentionally calorie counting. Nobody should count calories. You count total carbohydrates, and if you're eating a carbohydrate-free diet and your leptin is activated, you will eat and be satisfied for a long period of time with far, far less. And when you run out of what you've stored, or what you've just eaten, you can then tap into your stores, and that is how weight loss happens on an LCHF diet. It happens vicariously. We also have to help those patients to diversify and develop an action-based emotion management system. And over time, the final piece of sustainability is what I call arrogant integrity. When you offer a vegetarian a steak, they don't say, oh, no, I'm not allowed to eat that. Thank you very much. I'm not allowed to eat that. They get in your face. That's disgusting. How the hell can you kill Bambi? They're arrogant about the integrity they have that they don't eat steak, even though 5 years ago they may have been carnivores. We've got to help our obese and diabetic patients to develop that same arrogant integrity when they're offered carbohydrates. That's the way they protect themselves against a relapse. If they just say, oh, I'm on a diet, I'm not allowed to eat sugar, or no, I can't eat that right now, I just have a take, they're screwed. Because as long as they see their abstinence from carbohydrates as deprivational, it's just one emotion away from going back there. But when they develop the same arrogant integrity as a smoker, an ex-smoker, or as a vegetarian, that's disgusting. How the hell can anybody eat pizza? There's far less likely they're going to. So we want to help them over time to instill that arrogant integrity. So our goal with the LCHF diet, our goal is to get as close to zero total carbohydrates as they possibly can. And if you look at the total carnivore diet, which is okay, you can be anywhere from a total carnivore as long as you eat nose to tail, all the way through to a vegetarian who at least eats fish or cheese, or dairy or eggs. Though we at least want to get our sources of fat and animal protein in, that's kind of the limits. But most people can set themselves anywhere along that spectrum. I'm okay with that with my patients. I don't want them to be anything more vegetarian than having fish, eggs, and cheese, and obviously the carnivore side. But the goal is to get as close to zero. The reason why we use an upper limit of 30 grams of total carbohydrates per day in our practice, excluding vegetables, is because some incidentals do have carbohydrates. For example, if I put whole milk, a little bit of whole milk or cream in my coffee, there's 2 grams typically per cup. I have about 3 or 4 cups a day. That's 6 to 8 grams of carbohydrates that count to my total of 30. Now, I'm not using 30 grams as an upper limit to eat up to. If I've only eaten 5 the whole day, it doesn't give me permission to eat a chocolate chip cookie. The 30 is just there to be as low as you can be on that 30, but for awareness of incidentals. But we don't, because I've kept that number very, very low at 30, we don't count the vegetable carbohydrates. The goal of the LCHF diet is to change our food from being glucose or carbohydrate based to being real food that we used to get in nature, or we should get from nature. And for our blood glucose no longer to come from our mouth primarily, but for our blood glucose to come from our liver, from protein in the form of gluconeogenesis. And we want to live in ketosis, which is how human beings were designed to live. As your body develops, becomes fat adapted and develops a ketogenic way of life, the cells become comfortable burning fat as opposed to sugar. You slowly can reduce yourself to eating 1 or 2 meals a day. Breakfast being the least important meal of the day. Most people wake up in ketosis. The reason why diabetics have a dawn effect is because that's an unrestricted glucagon effect. We wake up in ketosis because our liver is producing blood sugar, but the ketones are still there. And breakfast, most people are least hungry in the morning, and breakfast did not come from God or nature. The concept of breakfast came from 2 brothers, the Kellogg's brothers, in the late 1800s, about 1890. They created the concept of breakfast, most important meal of the day, kickstart your metabolism. Those were marketing slogans that Dr. John Kellogg used in Michigan, in his sanatorium, to get people to eat cornflakes. You will not die of anorexia if you skip breakfast. So we try to get people to at least not eat before noon, and typically as they start to get hungry, you can have that noon meal and maybe eat again in the evening. So you're eating in an 8-hour block, and then for 16 hours you're not eating. That's the principle of the 16-8. a lot of the time in my life, like so far today, I haven't eaten yet, have consumed no calories. So I'm on a 22.2 for the most part because I am fat adapted. So you might be on a 16.8, but if you eat lunch and you don't feel like dinner, skip dinner. Or if you can't make lunch, that's fine. You're not going to die of anorexia if you skip that meal. So 16.8 or 22.2 are the principles that we try to use over here. You really want to reduce as low as you possibly can the glycogen that is stored in your liver. And by the way, you can cure a fatty liver within 48 to 72 hours on an ultra-low carbohydrate diet. I do this all the time when I do surgery. Fatty liver, whether it's inflammatory, with the non-alcoholic steatohepatitis, which is the inflammation that fat causes in the liver, which is actually a vascular inflammation, or just non-alcoholic steatohepatitis, fat in the liver, both of those are directly caused by the chronic excessive consumption of sugar. The liver takes up the sugar, converts it to fat, but the transport from the liver to the fat cells lags behind the production of the fat, and the liver becomes fatty. That's what we do to geese when we're making foie gras. That's what we do to cattle in feedlots. And that's what we do to ourselves when we're chronically eating sugar. So you can get rid of a fatty liver without any medication, without anything else, just by going on an ultra-low carbohydrate diet for 48 to 72 hours. We prove that in the operating room every single day I operate. That's a segue. So the goal there is to get our patients to have very low glycogen levels, particularly in the liver, and eventually in the muscles when the muscle cells learn to burn ketones, preferentially over fat. And we use intermittent fasting, and then the other thing that helps the liver to reduce its sugar content or its glycogen content is physical activity. I never, ever, ever use the word exercise. Exercise for a fat person or a diabetic person is usually a very horrible, bad thing. But everybody is capable of a degree of physical activity. And the physical activity is not there to burn calories. That's a ludicrous concept. The physical activity is there primarily as an endorphin alternative to carbohydrates, number one. But number two is to fool the liver into giving up a little bit of glycogen. And if the liver gives up a little bit of glycogen and you're not eating, the liver has to restore some of that glycogen from the fat cells, or at least use the fat cells and mobilize the fat. And in order to produce glycogen from the liver, unless you're a maladapted type 2 diabetic, and we can explain that in a second, your insulin levels are going to be low. So physical activity and intermittent fasting, as well as the low carbohydrate diet, is the way we get to be fat adapting. And when you do this, you will eliminate insulin resistance. Definitely stage 2, possibly stage 1, depending on how long you've been insulin resistant for. And the goal of this diet is to establish insulin sensitivity. And when you are insulin sensitive, you are and can be in ketosis, with a goal of an A1C less than 5, sugar of 70 to 85, and ketones in the 3 to 5 range, never going above 5 if you can help it. When you measure a person who is fat adapted as opposed to someone who's in ketosis, you can get into ketosis in 2 or 3 days by eating exogenous ketones. You can only get into internal ketosis when you are burning your own fat preferentially. And the way we determine the difference is by having a low blood insulin level. Even people in ketosis who have stage 1 insulin resistance have an elevated insulin level. But when your insulin level drops down to a low number, typically below 2 or 3, then we know, and you're not a type 1 diabetic, then we know that you're properly fat adapted. And you will not have any of the comorbid diseases if that happens. Our goal is, with our diabetics, and here's an interesting little concept, with our type 2 diabetics and our insulin resistance patients, eventually our goal is to get them on no medications. However, I do use low-dose metformin for my insulin resistance patients, 500 milligrams a day or twice a day, because what metformin does is it increases insulin sensitivity. And if they're not on aspirin for the first 3 months, I have them taking a low-dose aspirin to protect against that damage, that blood clotting damage, both from the diabetic perspective as well as the heart attack stroke perspective. So I do put my patients on these 2 medications from time to time to reduce risk and increase the insulin sensitivity. But the goal is to remove other diabetic medications very rapidly and thereby increase insulin sensitivity. I prescribe an LCHF diet and physical activity as my meal replacement. Physical activity is the best way to replace a meal. If I'm not going to have breakfast, I'm going to go for a walk. And that is an endorphin release, as I said, and glycogen depletion. The sustainability of the diet or of the way of life comes by treating patients from a substance abuse perspective, not from treating them with a diet. But you have to replace the deficit left by carbohydrates with real food and something that you do from a humanistic perspective for the endorphin activity. Everything I've just talked about can also be found if you Google this or buy a copy, and I would strongly urge you to buy a copy of a book called Diabetes Unpacked. I wrote chapter 4. There's about 12 authors in there, Tim Noakes being one of them. All the proceeds for this book go to the Noakes Foundation in South Africa. But everything I've just talked about is written in my chapter in this book, and I would strongly advocate this not only for you to read, but also to give to your patients. But ultimately, that is my management style and my introduction to the patients, that this is a substance abuse problem, not a weight problem, not a diabetes problem, and if we address the cause, all of the diseases go into remission. If you treat the disease without treating the cause, all you do is slow down the progression, but the result is inevitable. So I'm going to stop there. I know there may be some questions. These are some of my outcomes, and you'll see a lot of young people there. But if there's any questions, please, now's the time to interact with me.
Great. Wow. That was covering a lot of materials, actually, that's interesting. We haven't really got in, previously into sort of the psychological components and some of the addictive behaviors and that sort of thing. So that was really interesting to see that perspective. Okay, so for anyone who has any questions, please feel free to either put them into the instant messaging, or also the other option is just go ahead and start up your mic, and then I'll just call you out and let you ask a question. So while we're waiting for people to respond here, the one thing I really was interested in was this whole idea of how do you actually, when you're having that discussion with the patients, how do you introduce to them this whole concept in a way that they are able to sort of assimilate and take in, because obviously everyone is having so many different messages coming from the media, from their friends, from family. How do you get across in a succinct way? You've probably only got 30 minutes or an hour to spend with these folks initially. What do you say to them?
Yeah, actually, that was the talk I was hoping to give, but I couldn't find a way to draw. The way I sit down with my patients is, first of all, every patient that comes into my office is already an expert at failing weight loss programs. They've tried a whole bunch of things. They spent a lot of money. They may have lost some weight, but they've always gained it back. So we start there, and we explain to them why, yes, you have to reduce your caloric consumption to lose weight, but why SICO is a form of starvation. And the way I describe obesity to them, obesity is a bit like a polluted river. You can go down to that river's edge every day and take the crap out of the river, but until you shut the factory that's putting the crap into the river down, until you shut that factory down, you're never going to address the pollution. And obesity is exactly the same way. You've got to reduce your caloric consumption, but if you do it intentionally, it's unsustainable. If you do it vicariously, it is sustainable. But until you address the factory, and the factory is your consumption of carbohydrates, nothing's going to change. Then I actually don't talk about eating food or obesity at all. I use the carbohydrate analogy, the alcohol analogy. And I basically go down something that everybody understands. And I kind of draw this out. So look, if you look at all the fluids that human beings drink, our society has divided those fluids into two very distinct categories. On one hand, we've got alcohol, which is a drug. On the other hand, we've got water, which we use for hydration. We have to drink water, and our relationship with water, as I said in the discussion, is very tightly controlled. We don't drink alcohol for hydration. We drink it for pleasure. It is not necessary for human survival, and in excess, it causes harm. Well, when you look at food, and we understand that completely, and if you're an alcoholic, you have to get rid of the alcohol. We as a society don't quite understand that yet about carbohydrates. I tell the 50-year story where we removed fat and we added carbohydrates in, but that carbohydrates are a very powerful drug. And I separate the carbohydrates and food into the same categories I separated alcohol and water out. And most people understand, they can make that connection. And if you talk to them about, I tell them, look, don't believe anything I'm telling you right now. But all I want you to do is go home and look at three things. Number one, if human beings are supposed to eat once or twice a day, That's how our dogs eat. Most people feed their dogs once or twice a day. That dog doesn't die of anorexia. We're supposed to eat once or twice a day. Go home and look how often you put anything to eat or drink in your face. And the amazing thing is typically it's around 15 to 20 events a day. And that is almost identical to the average number of cigarettes a person smokes. Not like our dogs eat, our healthy dogs eat. So the first thing is the frequency. And then look at how effectively you discount the fact that you're actually doing that. The second thing you want to do is look at what the caloric content of those, or not the caloric content, but look at the total carbohydrate content of what you're actually eating. Whether it's a coffee from Starbucks, whether it is or Second Cup, I think, in Toronto, whether it is a little snack, a little bite, a little drink, look at the total carbohydrate content. And on average, our patients are consuming between 80 and 90% of their total calories as carbohydrates. So you challenge them. Go home and for 3 days, don't change anything, but just calculate your total carbohydrate consumption. And I don't care if it's an apple or if it's ice cream. Count the total carbohydrates, and they'll always come in as a percentage of your macros, and you will see that it's 80 to 90%. Now, if we're supposed to be eating less than 5%, look at that dramatic difference. The next thing I tell them, look, if you're eating 80 to 90% of your carbohydrates as sugar, where the hell is the fat that you're eating? How can we blame fat for your diabetes or obesity if you're not eating it? How can something you're not eating be causing so much damage? It is not fat. In fact, it's when we remove the fat from the diet that the problem happened. So that's the conversation I get. But remember, addiction, the last thing I'll just say on this, there's a book called, it's written by a guy called Prochaska, which is called Changing for Good. And it goes through the 4 stages of change of addiction. And the first stage is contemplation. The worst thing you can do to a new patient is give them a diet and say, off you go and do this. And that's what we love to do. Here's your diet, follow this, this is the way. No, they haven't even come to terms with the concept of substance abuse. So you get them to contemplate that. You see them back a week later, and you say, okay, where are you willing to make the first changes? Are you willing to give up the sugar in your sodas and go from a Coke to a Diet Coke? And I can talk about that if anybody has questions about that. Are you willing to give up the bread and eat stuff that goes on the bread without eating the bread? Where are you willing to make the changes? And let's add to these changes. I call that eating the elephant. I ask patients, how do you eat an elephant? Whoa, you can't eat an elephant. Well, carbohydrates are like a huge elephant in your life. You can't eat it in one go. But the way you do it is to break it up into little pieces and eat a piece at a time. And if you do it sequentially and you take a little step every day, you eventually get to know carbohydrates. You didn't get here in one day, you're not going to get away from it in one day. So the stages are contemplation, preparation and planning, and then you go to action and you keep building the action, you keep building the action. And then the final piece we challenge our patients with is to identify at least one thing that they can imagine themselves loving to do. Whether it's going for a walk, whether it's singing or music, whether it is going to church, I don't care what that event is, but something that is a primordial endorphin activator. And we start to build it in layers from there. I call it peeling the onion. And all I've done tonight, with the talk I gave tonight, was I've cracked the hard shell of the onion. And then our patients realize, wow, I have an addiction. That's the part when you peel it, when you're cutting the onion, you start crying. And then the next layer gets sweeter and sweeter and sweeter, but there's always another layer. So the final thing I'll say on this, and I'll take some more questions, there are no goals. You never, ever set goals for patients. You set milestones. And there's always another milestone to be had along this journey. And those are all the concepts that we work with our patients with.
Fascinating. Jillian, I see you have a question.
I do. Robert, thank you so much. It was really lovely to hear from you tonight, and I'm so glad that you could come and share your wisdom with this great group of people. I have a quick comment, and I have a quick question. I love the concept of talking about the damage that carbohydrates do. I think too often people believe that the damage that is being done is, depositing fat stores. They don't understand the level of vascular damage that is being done. So I think that was a really, really important message to come through. And also the motivational interviewing techniques that you're using with your patients, I think is also really interesting, and would be interested to explore if there was a tool that in fact could be developed. And I was wondering if you have any specific tools or handouts that you give your patients to help them with that contemplation phase.
Yes, I do. First of all, unfortunately, this format didn't work well, and maybe if so I really wanted to explain the theory behind this more from a medical perspective. What would be really nice is if I could sit down and basically conduct exactly the same first visit with a patient. What I do is I sit down with an old-fashioned pad of paper, and I draw things out, and I use the back of my I've basically got not a diet sheet, but the changes I want them to make sequentially. On the back of that, it's blank, and I draw out the carbohydrate addiction model as I've explained it to you today, so that they've got my story. They can look at the sheet of paper where they see the connections of the addiction of the emotion management system, and on the back end, they've got the starting points of the things I want them to do. And really, at the contemplation phase, all I'm asking them to do is to do two things. I'm asking them to don't eat or drink anything unless you absolutely know what the total carbohydrate content is, and record every single time you put something in your face. That's all I want them to do to begin with. And for the part I didn't get into is the difference between an authoritarian patient and a permissive patient. And we can go, that's a whole different topic, that's more psychology. But you've got to know your patients, because all too often we ask our patients to do what we want them to do, not what they're able to do. The authoritarian patients are patients who live in a world where they can put a lot of effort into stuff, but they're never quite good enough. And then so the return of the investment of effort is a wonderful sense of well-being that builds up self-esteem and self-confidence. When you set ridiculous expectations for yourself, and no matter how much effort you put in, you keep falling short, the very thing that should make you feel great and buoyant and dissipate emotion causes a sense of failure and an erosion of self-esteem and self-confidence. And those patients triangulate to drugs to soothe, numb, and obliterate those feelings. And carbohydrates being the current prevalent drug. 100 years ago, they would have been the alcoholics. 50 years ago, the smokers, and now the fat people or the diabetics. So that's one group. Those are the authoritarians. I can have very high expectations for those patients. I can make fairly rapid, big demands of them, and they're going to put a lot of effort in. Because those are the patients, when you ask them to go for a walk for 5 minutes, they'll go for a 20-minute run and nearly die. So we've got to help to dismantle structure for those patients, but they're tolerant of a fair amount of structure. The permissive patients are those patients who are very hedonistic. They have all the intent to put the effort in, but somewhere between intent and effort, they go sideways. So those are the people where rules are speed bumps. There's no structure in their lives.
Oh, I think that Robert got kicked out. To see if he can pop back in again.
You have me? Can you hear me?
Yeah. There you are. Yeah.
Okay, sorry. Yeah, we just dropped out there. So within 5 or 10 seconds of meeting a patient, I try to categorize them into either authoritarian or permissive. And those are, for the most part, the only two categories we get obese or diabetic patients from. And my treatment paradigm, my expectations of them are very, very different based upon which category they fall into. And I really have to work at the pace the patient is willing to go to. And I think one of the key quotes I use for them is, I don't care about success. What I care about is progress. And if you are continuously challenging yourself with little changes, it might be, hey, I'm just not going to eat breakfast. I'm going to have a cup of coffee for breakfast. Let's do that for a couple of days. Let's maybe go from Coke to Diet Coke. But a large part of the management is to remove the drug from your environment. You cannot have chocolate in a fat person's house and expect them not to eat it. Just like you can't have beer in an alcoholic's house and expect them not to drink it. So part of it is setting up the environment so that they don't have easy access to their drug of choice. And you progressively help them to clean out that environment and convert the people around them, because it's very, very difficult to live in a crack house and quit smoking crack. So these are all the little sayings. These are all words that I use with my patients. And you develop your own set of stories that you tell with them. But ultimately, that's the way it goes. You engage them slowly and progressively, And the speed and the acceleration of the process depends on what the patient can do, not what you expect them to do. So hopefully that makes some sense.
Excellent. One really quick question, because I'm looking at the time here. We're coming to the top of the hour. Quick question is, what method do you get your patients to determine carb content? Do you suggest a specific app, or what approach do you take?
You know, everybody comes up with different apps, and there's net carbs and total carbs. I just tell them to Google it. And for the most part, Google will give you the answers within a few grams. Because I'm not macro focused, I'm not specific. I don't want to know whether the apple has 25 grams or 20 grams of carbohydrates and whether it's fructose. I just want to know that there's a hell of a lot of sugar in an apple and I should stay away from it. The place I really want them to be aware of the absolute numbers, and it's there's something here in the US called the Calorie King, which is a good place to go to, or often it's written on the labels, are the incidentals. What's the carbohydrate content of ketchup? What's the carbohydrate content of this mayonnaise? What's the carbohydrate content of the milk or the cream I'm putting in my coffee? It's those incidentals where I really want them to be very precise. For the bigger items, they either are or they're not, and the numbers are huge, and I educate them about that. So for the first 6 months or so, I want them to be very fastidious about the carbohydrate content. They need to know the number. Eventually, for example, in my life, I've been doing this personally for 13 years. I don't know the exact numbers, but I absolutely know whether I should or shouldn't. And it's a should or shouldn't. It's a binary discussion. It's not, I can have a little bit. I can have a quarter of a banana because that's 10 grams of carbohydrates, or a third of a banana is 10 grams, and I'm still under my 30. It doesn't work that way. It's binary. You either did or you didn't. And early on, knowing the numbers to know where they are is important, but Google will tell it to you anywhere. So I don't have specific apps. I don't have sheets of paper I give to the patients. The empowerment is to help them to figure out once they know the principles. I'm not there to dictate to them. I am there to share principles with them. And if we keep the principles very, very simplistic, and they can adhere to it, and then they come back and you can augment those principles. The key thing is, this is AA for fat people. You want multiple visits with them on a regular basis. And they'll come with questions. The engaged ones will come and ask you things. And even if they're making mistakes, you help them to correct those mistakes. So I find that's a much better way than absolutely calculating macros. We get too engaged in the macros rather than the principles of addiction.
Excellent. Well, we're at the top of the hour, so thank you so much, Robert. That was excellent. You covered a lot of materials and provided a lot of additional in-depth review of some of the different areas, as I say, that I haven't seen before in terms of the psychological impact and the role of addiction and that kind of thing. So thank you very much. I really appreciate it. And thank you, everyone, for joining us this evening. And as I mentioned, Andrew Mente is going to be talking about the Pure trial in October, on October 11th. So please keep an eye out for the poster that we'll be putting in the community. And thank you very, very much again, Robert. And we'll hopefully everyone has a wonderful evening, and we will be talking soon.
Great. Thank you very much. And I really love what you guys are doing in Canada. I wish we could be as far advanced as you guys are. Thanks so much for having me.
Okay. Thank you very much. Take care, everyone.